Hello everyone, welcome to my channel. Traumatic ulcer is the most common oral ulcer, and most common non-traumatic oral ulcer is aphthous ulcer. It is a very common and painful experience for a patient. Recurrence is its characteristics. But if some trigger factors are addressed properly, then the recurrence can be reduced to a great extent. Aphthous ulcer is a recurrent oral immunological ulcer of multifactorial origin. It is also known as recurrent aphthous stomatitis, aphtha or canker sore. Activation of cell-mediated immune system with subsequent destruction of the epithelial layer of the mucous membrane is the underlying pathogenesis. Aphthous ulcer is of three types: minor aphthous ulcer, major aphthous ulcer and herpetiform aphthous ulcer. When aphthous ulcer has the diameter less than 10 mm, it is called minor aphthous ulcer, and when it is more than 10 mm in diameter, it is called major aphthous ulcer. Minor aphthous ulcer occurs more frequently in more than 80% of cases. It occurs on the front side of the mouth, typically multiple but less than 10 in number. Minor aphthous ulcer lasts for about 2 to 3 weeks, then heal without scarring. Major aphthous ulcer most commonly found on the posterior aspect of the mouth. It is usually single in number. It can last up to 3 months and it can heal with or without scarring. Herpetiform aphthous ulcers are less than 5 mm in diameter. They are multiple, about 30 to 100 in number. They heal without scarring. Now come to the clinical features. Aphthous ulcer is most commonly seen in childhood and adolescence with a slight female preponderance. It starts as a small vesicle, then the vesicle becomes ulcerated. There is a central necrotic base of ulceration which is whitish, greyish or yellowish in color, and it is surrounded by an erythematous halo. These ulcers are superficial, very painful and involve the movable mucosa of the oral cavity, that is upper or lower lip mucosa, soft palate, cheek mucosa. It does not involve hard palate or gingiva. The aphthous ulcer can last for 1 week to about 4 weeks, and eventual remission is its natural history. When a patient suffers from recurrent aphthous ulcer from childhood, then most likely it is genetically predisposed. But there are some environmental and health related trigger factors. These are stress, trauma. Interestingly, it can occur in a person who has stopped smoking. It can occur in case of hematinic deficiency like deficiency of iron or ferritin, vitamin B12 and folate. These deficiency can be present even in absence of anemia. About 3% of patients with recurrent aphthous ulcer has celiac disease. It can also occur due to some viral and bacterial infections, food allergy and hormonal changes are other trigger factors. The diagnosis of aphthous ulcer is usually clinical, no tests are available. In case of recurrent aphthous ulcer, the underlying trigger factors should be sought for. We can screen ferritin level, B12 level and folate level for hematinic deficiency, and a screen for celiac disease is also recommended. Now come to the treatment of aphthous ulcer. The underlying etiology should be sought for and corrected. Patients should maintain good oral hygiene by mouthwash like chlorhexidine mouthwash, diclosan mouthwash. Steroid oral paste like triamcinolone can be used. If there is failure with triamcinolone, then more potent steroid oral paste can be used like mometasone, fluticasone, beclomethasone, betamethasone. In severe case, a 1 week tapering dose of oral steroid can be given. Amlexanox oral paste is also used. 250 mg of tetracycline after mixing with 10 ml of water can be used to gargle 3 to 4 times a day and then swallow it. Thalidomide is sometimes used to induce remission of aphthous ulcer, but it has the risk of neuropathy and teratogenicity. It can induce remission but cannot prevent recurrence. Lactobacillus capsules are sometimes useful. Sodium lauryl sulfate, an ingredient used in some toothpastes, is also a trigger factor. So, patients should avoid any toothpaste containing sodium lauryl sulfate. Dietary triggers are benzoate, chocolate and cinnamon. Benzoate is a preservative that is used in ice cream topping, sauce, fruit juice, milkshake, commercial pickles. Cinnamon is a spice that is used as a flavoring agent in ice cream, dessert, soups, sauces and flavored rice. Patient is encouraged to maintain a food diary to identify which food is triggering his aphthous ulceration. There is a similar condition like aphthous ulceration which is called Sutton's disease. In this condition, there is major aphthous ulceration with deep crustiform ulcer, and there is presence of constitutional symptoms like fever and lymphadenopathy, which are absent in classical aphthous ulcer. So, grayish necrotic base with surrounding erythematous halo is the classical aphthous ulcer. But is this kind of lesion is only present in aphthous ulceration? The answer is no. This kind of lesion can also be found in Behçet's disease, Sweets syndrome, HIV infection and immunodeficiency. That is all from aphthous ulceration. I hope you have enjoyed today's session. Thank you for watching. Goodbye.